Hello and welcome to the Oncology Journal Club podcast, where oncology papers meet real-world practice. I'm your producer, Rachel Babin, and joining me again are Professor Craig Underhill, Dr. Kate Clarke, and Professor Christopher Jackson. Together, they dive into the research shaping cancer care, the important, the intriguing, and the sometimes controversial. This podcast is proudly produced by the Oncology Network. Okay, over to you, Craig.
G'day. Welcome to Series 4 of the Oncology Journal Club podcast. We've got new music and some other new features in this series. Firstly, look out for the WhatsApp link at the end of the podcast notes. You'll be able to type in some questions or comments or record them with the voice file. I learned something new. Apparently, when you're on WhatsApp, if you open a chat, you can click on the little mic button in the bottom right and record. So please send us in your comments or questions and we'll feature them in the subsequent episode. We often from time to time mention what we find as helpful tools or guidelines or things like the ESMO relative scale of benefit. We're going to start adding those to a page on our website so people can find them more easily. We've had some very good feedback on the episode with Professor Nathan Cherney on when is enough, and it's really been some quite impressive positive feedback on LinkedIn and other social media about that. So congratulations, Chris and Rachel, our lovely, efficient producer. So if people haven't had a chance to listen to that, I urge our listeners to do so. So let's let the Kiwis into the room. So if anyone needs to turn on closed captions, please do so now. Professor Jackson, hello.
Oh, well, kia ora, Craig. Look, I've been staying away from social media. Do you mean that social media feedback was from someone other than my mum?
Yes, at least one person wasn't identified as your mother.
Oh, well, that's unusual, but I'll have to check that out. So OJC is active on what social media channels, Craig?
I saw this particular feedback on LinkedIn. We also had the presence on X and Blue Sky.
That sounds fantastic.
We do have Facebook.
Oh, we do have Facey. Oh, so if you want to see some negative comments to the episode, hop onto our Facebook page.
So we get positive comments. No, hang on. We must get all the negative comments on X, mustn't we? And all the positive comments on Instagram.
And LinkedIn.
Yeah, LinkedIn is a great place to find us. If you follow Oncology Network, then you'll get the OJC update.
It's just the photos on Insta, CJ. Yeah, that's what attracts people.
G'day, Dr. Clarke. How are you going?
Very well, Craig. Very well indeed.
Terrific. I think you're going to lead us off on today's podcast, Kate. It's an interesting paper. Tell us all about that.
So I want to talk about a topic that's increasingly close to my heart, Elinzanetant, used for vasomotor symptoms, aka hot flushes, in those women who are taking endocrine therapy for breast cancer. Written by lead author is Dr. Fatima Cordoso, who breast cancer treaters will all know from the ABC Global Alliance, so Advanced Breast Cancer Global Alliance. And just so you understand how severe this is for women, and a little bit of personal story, I probably have 1 to 2 hot flushes on a bad day. To get into this trial, you had to have moderate to severe symptoms, which was 11.4 on average, moderate to severe hot flushes a day. So that means no sleep, it means embarrassment, it means changing your clothes. So this is a significant issue and is a reason a lot of women are not compliant with their endocrine therapy. So Elinzanetant is an NK1, NK3 antagonist and has already been used in women going through natural menopause, whereas it about halves the rate and severity of hot flushes and sleep disturbance. And those trials, if you're interested, are called OASIS 1 and OASIS 2. So this trial, OASIS 4, looked at a dose of a tablet a day for these women, and I quite liked the randomization. So what they did was they randomized 2 to 1. 2 out of every 3 women were started on Elinzanetant and were to take it for the whole 52 weeks. 1 out of every 3 were on a placebo for 1 to 12 weeks and then switched to Elinzanetant. And this strategy is really common in a symptoms trial because the waitlist effect is where symptoms that are distressing get better with time anyway. And you want to see what happens both during that wait period, but also when you switch people to an active agent. So at 4 weeks, those on the tablets had gone from 11 events a day to 5 events a day. Those on the wait list had only lost 2 or 3. And at 12 weeks, that was down to 3 events a day versus a sustain of that initial drop in the placebo group. Later, when both groups of women were on active agent, the women who had been on placebo caught up and got that benefit. And so everybody ended up at the same point. There was no difference in the PK of either Elinzanetant, comparing it with OASIS 1 and 2 women, because these women were on adjuvant hormones, and no different in the PK of the adjuvant hormones. So the toxicity was fascinating. Women on Elinzanetant have fewer headaches than women on placebo. Slightly more fatigue, slightly more somnolence. But when they offered all women at the end of a year another 2 years Elinzanetant for free, 91% of women said, yes, please. So I think that is potentially the best safety data that we have available. So I'm very excited by this. It is hundreds of dollars a month at the moment. So relatively affordable for an anti-cancer therapy. And if you attach that, they didn't do compliance with hormones, but if you attach that to the compliance with hormones, compare that with something like ribo or adjuvant ribociclib, it's significantly more affordable. So yeah, I was really impressed.
Yeah. So that's great, Kate. Tell us, what do we have available now as a sort of standard of care therapy to support women who are getting severe vasomotor symptoms associated with endocrine therapy?
So currently we have some very good non-pharmaceutical methods. So yoga, other mindfulness, cutting out caffeine and alcohol, which I think is immoral. And then the pharmaceutical methods, gabapentin, venlafaxine and oxybutynin, all help about a third of women. But as I tell my patients, it's not a third. They seem to help women who do well. And there are some women for whom they don't get benefit at all. And this does mean that the significant number of women beg me for permission to stop.
And do you think that this drug might have a role outside of women with breast cancer having endocrine therapy to work from more broadly?
Yep. So I did read only a couple of sentences on a Google search that it is being trialled in men with prostate cancer as well, because obviously men on GnRH agonists suffer, or the old-fashioned orchidectomy, suffer significantly also hot flashes and mood changes and anxiety that are common in menopause. So I think this may well have a role in all those who are being hormone starved.
Yeah, okay, so interesting stuff. We might have invented a new clinical trial endpoint, proportion of subjects who take up taking the investigational drug beyond the lifetime of the trial, 91% positivity there. That's a really interesting result.
I think that's a really important patient outcomes that matter thing there, isn't it? What you really want to know is when people use throwaway lines such as the toxicity is manageable, blah, blah, that line drives me nuts, because who gets to define what toxicity is manageable?
Yes, we know that, Chris. You do mention that from time to time.
Once or twice. Well, I'm glad that people are starting to recognise my hatred of that particular line. But in terms of the, and the word compliance, I struggle with a wee bit too. I think adherence is one more preferred one, but showing that people actually wanted to stay on the treatment at the end is a really good endpoint. When we ran our study of oral paclitaxel versus IV, we gave patients the option of staying on the oral or switching to the IV, and that was a really important endpoint for us too, because people preferred the oral, and that came through so much more strongly than all the other toxicity stuff that you did. A basic preferences question.
Yeah. Just while we're on phrases that people hate, I can't stand no new safety signals, because you're like, yeah, so 8 people died of pneumonitis, but we've seen that before.
When we deal. Yeah. All right. Professor Jackson is currently in India. It's we're a global crew this week. We have Rachel in Spain. I am in Bordeaux. And Professor Jackson is somewhere on the subcontinent.
Yeah, so I'm in central India, in the province of Chhattisgarh, in a place called Raipur, helping out with some teaching at a friend of mine's who runs a hospital here. And I just really want to shout out to my colleague Bhavna Sarohi, who is an absolute global superstar, who's the medical director of her hospital. And the program she's running over here is fantastic, improving education. And also one of the goals of her hospital is to make treatment available for the people of her local community where head and neck cancers and cervical cancers are absolutely rife. And the amount of work that her hospital does to meet the needs of those who have otherwise no access to healthcare at all is nothing short of staggering. So I'm never going to complain about my workload again after coming over here and seeing how hard Bhavna and the team work. So big shout out to those guys. The big study I wanted to talk about this week is one that people may have come across. That's the Alaska study, which is the randomized double-blind placebo-controlled trial of aspirin. Now, we have seen a number of studies with aspirin and colorectal cancer before. In context, we had the Physicians' Health Study, which was a primary prevention study of 22,000 people, where people took a full-strength aspirin every other day or placebo, and they had reduced colorectal cancer risk after 10 years. The Women's Health Study of 39,000 people of aspirin 100 mg every other day, and found there was a reduction in colorectal cancer after 10 to 15 years. And, of course, the AGITG's own ASCOLT study of aspirin for stage 2 and 3 colon cancer that was unfortunately negative for DFS at 3 years, but let's hold on for a bit more data for a few more years, given that it's often a late signal. And then we know that aspirin has benefits in COX-2 expressing tumours, which led to the celecoxib prevention studies, which showed a reduction in adenomas, but unfortunately killed people with an increase in cardiovascular events. But, Kate, no new safety signals. We knew that already about the COX-2 inhibitors. And this is important because the PIK3 kinase pathway is upregulated in COX-2 expressing colon cancer, which is a subgroup of colorectal cancers. So the Alaska study was my favourite study design of all. Randomized, double-blind, placebo-controlled, with overall survival as the endpoint. It could not be better. What a beautiful study. Patients who were eligible had stages 1, 2, or 3 rectal, or stage 2 and 3 colon, and had 160 mg of aspirin a day or placebo, and they were checked for somatic mutations in PIK3 pathway genes. Now, there were 2 categories of PIK3 kinase genes. So Group A was exon 9 and 20, which are the ones that most of us are familiar with our extended panels. And then those were then Group B, which had other moderate or high somatic variants in PIK3 kinase, PIK3R1, and P10. So there were 3,000 people who were screened prior to surgical consent, and alterations were detected in 1,100, so almost a third. And then those who met all the inclusion criteria ended up being about 600, 310 in each arm. And to cut a very long story short, the 3-year recurrence rates were 7.7% in the aspirin group and 14.1% in the placebo group. So an almost 7% to 6.5% reduction in events in the aspirin group. There were 3 deaths with aspirin compared to 1 with placebo, and there were more GI side effects and an overall 9% increase in toxicity with aspirin. Those 2 additional deaths with aspirin balanced off against the cancer survival. There also appears to be a gender interaction, which is absolutely fascinating and wasn't something that I'd read before about PIK3 kinase or aspirin studies. And the question was that a dosing thing? Because obviously men have generally got higher weight, and so would that make a difference in the gender? But apparently they did explore for that and found no relationship between weight and a benefit there, so they did control for that variable. And so that remains exploratory. So overall, I think this is really exciting. This is a study which uses a low-cost drug. The high-cost thing here is the screening for these variants, and there's, at least 5 of them. So that's going to mean probably a panel on your stage 2 and 3 colon cancers rather than just running a bunch of IHCs. So that will add to that molecular cost. But, 6.5 to 7% in terms of prevention, that's almost as much as exercise, and it ranks as another really good intervention there for our stage 2 and 3 colons or our stage 1 through 3 rectals.
So, wow, that's really interesting stuff, Chris. But this fellow said there was a couple of excess deaths on the aspirin. How many lives were saved across the group of participants?
So, okay, I did actually get my intro wrong when I said it had overall survival as its primary endpoint. It didn't. It was disease-free survival initially, so we do have to wait a little bit longer for overall survival. So we don't have the overall survival data I don't think it is yet, Craig, but the DFS data is 6.5 to 7%. So number needs to treat around 12 to 15, which is again a pretty good strength, and it's again similar strength to oxaliplatin for a drug that's a whole lot less toxic.
Yeah, that's right. It's fascinating, isn't it, how as we understand the biology or the biomarkers of these common tumours, we're getting these smaller subsets and may be able to stratify treatments accordingly. So,
Yeah.
as always, it's an exciting field for us to be working in, really.
Yeah, it really is. And I think, Kate, we're going to segue into you in a wee bit about one of your papers too, about the different genomic stratifications of colorectal cancer too. So the colon guys are feeling left out by the lung and breast team, so we're trying to catch up.
No, she says.
I'm looking flummoxed.
I like some words to that silence. There was a bit of confusion.
When you're doing early onset colorectal cancer, Kate?
Yeah, but only from an epidemiological point of view.
Oh, okay. That's not the genomic ones in Lancet.
No, you've got to remember, I'm not academic, so I only get access to everything that's like open source these days. Yeah.
But it's because you mean you're referring now to the restrictions on the journals by the health service?
Yeah, that I am.
Yeah.
Yes. Yeah.
Well, Kate, would you like to then, would that be a segue for you to tell us about that paper that you had selected?
Oh, lovely. So look, I think this is something we all know, but I think it's useful to have it documented. And if there are any health planners listening, please listen to this one, right? Okay, so this was a paper by Professor Sung, who works for the American Cancer Society, published in Lancet Oncology this week or last week, looking at colorectal cancer incidence trends in those who are called early onset, under 50, or usual onset, over 50. And the relevance to our New Zealand and Australian listeners is that the Australians rate number 1 in incidence of early onset colon cancer. New Zealand, it's 5, we're on the podium, we're number 3, compared with our respective rates of those over 50 of 8 and 10. But more concerning is that although the rates of older people getting colon cancers are falling by about 2.5% a year, the rates of young people getting colon cancer is increasing in New Zealand by 4% a year, in Australia by 3% a year. The epidemiologists feel this is a birth cohort effect, so this is not a blip. These people will just keep getting more colorectal cancer as they go through their age cohorts. So we will lose all of the advances we have in the falling incidence in older colon cancers as these people age, is their best guess of what's happening in the epidemiology of it. And then the rest of the paper presents all of the stuff we're working on, the suppositions as to why. It has to be an environmental or lifestyle exposure. To what that is, I think there's a lot of questions still hanging over everybody's head. But I think the most worrying thing for planners is that the rates of young people's colon cancer is rising, but as those young people move through the older cohorts, their incidence is not expected to drop off. It is expected to keep at that higher rate. And so we will need more colonoscopies, more surgeons, more oncologists, more scanners to look after the colorectal cancer epidemic that is on its way. So it's been sobering.
And of course, Kate, given in our current screening guidelines, adjusting down the age, making primary care physicians and patients aware of suspicious symptoms so that they do present earlier or are able to be picked up in screening, which is so effective in colon cancer.
Yes, definitely. And the move into nurse practitioners being able to do scopes, all of that is something we're going to have to take in our stride and to fund appropriately, because it's so much better than to screen than it is to treat somebody as a stage 3, how expensive that is and how morbid that is for the patient.
Yeah, so there's also a article in August's Lancet Oncology, which is looking at the genomic differences in early onset colorectal cancer versus late onset, and they're clearly different in molecular. Now, lots of the historical literature has actually said, look, young people's manifestations and natural history of colorectal cancer actually pretty similar. It's just they present later, but stage for stage, it's pretty similar. That had been shown a bunch, but this is a different disease which is coming through in these younger people. 3 to 4% a year is in of itself not that much, because only 10% is under 50 anyway, and 3 or 4% of 10% is not very much. But I think more concerningly, like you said, Kate, is that if it's a birth cohort effect, it'll get bigger as they get older, which is perhaps where it's going to be important. And I think we have to understand, as you've already highlighted, what the causes of it are, because that's actually where we can get to trying to prevent it. And undoubtedly it's going to be microbiome related, but what are the key features in that microbiome and how has it been manipulated, which are causing that? I've heard people talk about microplastics. I've heard people talk about antibiotic usage, obviously processed food, nitrates in water, etc. So there's a lot of theories there, but a hard area to study.
I think the other concerning thing for me is if this is truly a birth cohort effect as a result of an environmental exposure, I can't believe it's isolated to colon cancer.
Yeah.
So we maybe we are seeing the beginning of it in biliary cancers in young people.
Right.
In my personal practice, pancreatic cancer in young people. But and one of my I fall in love with all of my patients, but one of my delightful people in his early 30s with metastatic pancreatic cancer said to me, what have we done? And I said, oh, sweetheart, if only we knew, we could stop doing it. But yeah, we've done something. It's a very sobering thought. Should we cheer up?
It's important also to know that we have video of each other on this podcast where we can see it, and Craig just got up to open his curtains while he's in Bordeaux. I was quite concerned for a moment that Craig was doing the old Zoom thing of not wearing any pants.
No, I've got my red French shorts on. I'm definitely wearing pants.
I'm not sure the red shorts are much better, Craig, to be honest. Ladies and gentlemen, we have knees.
I'm going to screenshot that for my favourites file, or maybe make it my new screensaver.
Right. Okay.
Before we get back to the papers, if there's a study you think we should be covering on the Oncology Journal Club podcast, feel free to send it our way. You can join the Oncology Network. Remember, registration is free. And leave us a voice note on the OJC page. That's at oncologynetwork.com.au. Or come and chat with us on our socials. And physicians, please don't forget that you can claim CME points for listening to the show. All right, back to the Journal Club.
So just changing tack a little, I want to talk about an ASCO guideline, geriatric assessment ASCO global guideline. This was published in the JCO. One of the co-authors is our very own Bogda Kozwara, who is lead on the Supportive Care Matters podcast. Many of you probably subscribe to that. And if you don't, you may want to. So Bogda runs a great series focusing on how we can improve supportive care for our patients. So she was an author on this guideline, which was a multidisciplinary, multinational expert panel who reviewed existing ASCO guidelines and conducted a modified adapt and a formal consensus process. So this is a podcast. I'll just mention briefly that this adapt methodology is an alternative to de novo guideline development. The objective of the adapt ADAETE process is to take advantage of existing guidelines to enhance sufficient production, to reduce duplication, and to promote the local uptake of quality guideline recommendations. So this guideline focused on an important issue. Chris is in India at the moment, Kate's in New Zealand, and I work in regional Australia. And the relevance of that is the panel wanted to look at, what are the recommendations for managing older people with cancer over the age of 65 in a system of basic resources, a system which had more enhanced resources, and then a system that has fully enhanced resourcing, so able to offer a wide range of supportive therapies to patients. So there's a table with 3 columns, basic, limited, and enhanced, with suggested ways to manage various deficits identified in older people, whether it be physical or functional, nutritional, weight loss, an absence of social supports, depression, anxiety, and comorbidities, cognitive issues. So for each one of those domains, there's suggestions, practical suggestions in this guideline of how to assist and put in place some management steps to better support the patients. Overarching all this is a recommendation that all people over 65 who are proposed to receive cancer treatment should undergo a screening assessment, and that could be a simple G8 score. I don't know, Kay or Chris, if you've had experience using that in your practice, but in Albury-Wodonga for a number of years, that's routinely done by the treating oncologist at the time of the first appointment and subsequently through patient's journey. It takes a couple of minutes to do, and it quickly identifies people who may have a deficit and then need a more comprehensive geriatric assessment, either with a specialty nurse or referral onto a geriatrician if they're available. So very interesting and practical guideline, and as I said, sort of divided up in mind with comprehensive centres, not so comprehensive centres, and then basic centres or services with their recommendations. So congratulations to Doctor and the co-authors for leading on that.
And genuinely practical, including a practical geriatric assessment that has a link to that you can then use for those under-resourced centres who do not have availability otherwise. So I thought that was really helpful.
Yeah, that's right.
Do you use the G8 score routinely, Kate?
No, I don't. But actually looking at it, I think I do a very sort of similar thing. Like I took a very sweet young man today for a walk, and we made a cup of tea together. So, that is a way of sorting out the sweet from the chaff of your old people. If you can keep up with me, you can probably deal with chemotherapy. But no, I don't use a formal G8.
Well, Craig, as you're getting closer to 65, what do you think about the cutoff of 65 as defining older adults? I mean, to me, it's 80 is the thing.
I'm at least 2 years away from 65, Chris.
I thought it was 65 if you had significant morbidities, and we've seen his knees now, so he's probably got all of that football. Yeah.
But I think, though, to me these days, 65 is a typical age patient in our clinic these days. 65, is normal in an oncology clinic, really. I mean, it's the 75 to 85, 80 plus, I would say, who are the ones who present with real frailty and stuff in the 75 group if you've got morbidity. But there's very, very, very many very fit 75-year-olds out there.
Yeah, that's right. But that's why you do the G8 score, Chris, because it's not the age on the clock, it's how the engine's running. And that's coming from a 62-year-old who was just part of the Albironga over 35 soccer championship winning team this year. But so there's 65-year-olds and 65-year-olds, as you say, and that's why that's just an arbitrary cutoff, a suggestion that rather than a fairly subjective follow me up to the tea room test, it's a series of questions. It really literally takes a few minutes to do, and people can present as looking like a pretty fit 75-year-old or a 70-year-old, and then you apply these questions and it reveals that in fact there may well be a deficit and requires further, more comprehensive testing. So it's just a screening tool, and I think very quick to do, very practical.
So outside of our personal experience, because obviously Professor Jackson and myself in the coming months can have our early onset colorectal cancer. You're not 50 yet, are you?
No.
Very close, very close. It's available on NT Calc G8 if anybody uses that free app.
Yeah. It's widely available free online, various websites. It's a tick score. If you're doing the ECOG or staging, it takes about as long as that to do. So, all right. Chris, what else do you have for us?
The next trial I wanted to talk about was the Spring 01 study, which is just out in Lancet Oncology. This is a phase 2 randomized study in locally advanced rectal cancer. Patients will receive short course radiotherapy of the Rapido style, followed by Capox chemotherapy, and half were given the PD-1 inhibitor sintilimab or sintilimab. The primary endpoint was pathologic complete response, which I don't think is a great endpoint, but I'm going to talk about that in a moment. And PCR, of course, is the complete absence of tumour in the viable tumour and suitable specimen. And the result, just to, again, cut to the chase, is the sintilimab achieved a PCR response of about 59% compared with 33% in the chemo-only group, which is a big, big step up. And that's the first randomised signal that adding a PD-1 inhibitor to TNT, total neoadjuvant therapy, might really enhance tumour clearance. On toxicity, this was interesting. Grade 3-4 adverse events were similar, around a third of patients in each arm, but there were more adverse events, and particularly post-operative complications with sintilimab, which we're not seeing with other PD-1 inhibitors at this time. So it's going to need a bit more follow-up there. Now, why is this one interesting, and why have I highlighted a PCR study? Well, because elsewhere, adding PD-1 to chemoradiotherapy has not been a slam dunk. In head and neck cancer, both Javelin Head and Neck 100 and Keynote 412 were negative. And in rectal cancer, the NRG platform study with pembrolizumab showed no clear benefit, and even smaller neoadjuvant studies like Voltage A showed activity, but not of this magnitude. So Spring 01 really does stand out as a positive randomized study in those with microsatellite stable, so not DMMR, rectal cancer. And so that is tantalizing. We do have to temper our excitement because PCR is not a perfect endpoint and doesn't always translate into survival, and it can be misleading in isolation. What it does show is that PD-1 inhibitor in operable rectal cancer may be a target we're going to see more of in that TNT setting.
The sintilimab was run with the K-POTS, not with a short course. Yeah. So do you think it was the timing of the IO? Do you think giving IO and then an awful lot of radiotherapy is immunosuppressant? Or do you think this is just a red herring?
Yeah, look, I think that's hard to know, Kate, but I think they're all really good points because all those other studies that I'd highlighted were longer course radiation studies, weren't they? So, over multiple weeks rather than just one. So the hypothesis that maybe it's related to short course versus long, that's a really provocative thought. I'd been focusing more on the disease site, I suppose, the rectum and the overall regime rather than thinking too much about the length of the course, but that's a good hypothesis.
So where to next with this drug? Do you think, Chris, will be there further studies or...?
There'll have to be, really, Craig. I think that sintilimab is clearly a fast follower in terms of the world of PD-1. So it's an IgG4 monoclonal antibody different to IgG1 and IgG2, which is your Pembros and your Nivos. Whether or not that's relevant or not, I doubt it, probably. But when you're getting a signal like this, you can bet your bottom dollar the company's going to double down on the indication and expand that quite rapidly. Clearly not anything which is ready for prime time and nothing that I'll be talking to my patients about in the near future. But certainly something that I think it's a space to watch, and something that if that trial did come along and be offered to my centre as part of a collaboration, I'd certainly want to pick up on and participate in further studies of it. Fantastic.
Kate, I think you're going to tell us something about ChatGPT that you found potential tool.
Well, I think this is a long way from prime time, but I thought this was interesting. So this was a group from Yale. Dr. Lisa Chan led them. Now, I know less about computers than my mother. So here we go. So they used large language models, ChatGPT and ChatGPT-1 Pro. So physicians acted as patients. So that's first bias. And they asked the large language models to triage when these pretend patients, who were all oncology physicians, rang in with common problems that women who are having treatment for breast cancer in the early, late and survivorship setting might have. Interestingly, of those 66 scenarios, which they tested multiple times, 97% were given medically appropriate advice. 89% of the replies had the correct diagnosis as number one. 98% had the correct diagnosis in their differential diagnosis. 92% had highly appropriate triage decisions. So this group want to take this into a group of real patients. They wonder whether doctors ask questions differently than patients. So I think that's probably fair because we use different language. But even if this could be used as a screening tool to, I don't know how your centres work, but we have a triage nurse who's on the phone the whole 9 hours, and that's a very expensive use of somebody's time. I thought this was intriguing. And so I looked for more work from Lisa Chan and her group. And it was also in a journal called Journal of Clinical Oncology, Oncology Advances, which was actually quite an interesting read.
That really surprised me, Kate, because a lot of the corporates are using chatbots, for example, to help you sort stuff out, and chatbots can't even help me amend my flights. So how they're going to actually be able to sort out people with breast cancer symptoms is a bit of an advance.
Interesting. So they did have an example. So the person asked, "Hello, this is Dr. Smith. I understand you've developed some new symptoms. How can I help you?" "I am having bad aches all over," said the patient. "I'm sorry to hear that. Can you tell me where the aches are, in muscles, joints or bones?" And the patient says, "In my joints and bones." "Thank you. Have you been receiving any supportive medications recently?" "Yes, I did receive Neulasta after my last treatment, which is a granulosed colonized stimulating factor." "Thank you. It sounds like this bone pain may be related to the Neulasta." Blah, blah, blah. And then the patient says, "I got my last shot 4 days ago and it began about a day after I got the shot. Based on what you've described, the timing of your bone aches and the pattern of pain, the most likely cause is pegfilgrastim-induced bone pain." And then they assess them. So I think there was a very narrow group of things with the patient. So the patient had very exact language. I agree with you. I can't stand the one on the supermarket apps, and the airline ones are worse, useless. but maybe they haven't been investing enough money and time in training them.
Oh, look, 100%, AI is here, and our challenge is really how do we integrate it and how do we best maximise its use in the clinics to bend the curve of the work demand, right, the workflow demand. We've been using ambient listening in our clinical practice, in one of our practices, and that's been going really, really well. My GP's using it in his practice as well. It's going really, really well for him. And so I think that that'll be something that we're all going to do in the very near future, I would anticipate. And it's an exciting time, and it really feels like the next big change, or the biggest change since you all got cell phones and emails.
Exactly. And I think we're going to have increasingly numbers of these kind of papers on the program as ChatGPT and other AI tools brought in to help support our interactions with patients, and something that we're probably all going to need to try and understand a bit better. So I'm just going to change track a little bit now. I just wanted to highlight briefly a major report that's come out from Rare Cancers Australia. It's entitled Now It's Personal, Access and Equity for All. So it's a review about the issues and evidence in this space about the issue of inequity of access to treatment and support for people with rare cancers. There's about 80 references used in this report, but they highlight a couple of interesting facts about delays in diagnosis, waiting time to get treatment. There's a higher, so there's some blowout in times for people with rare cancers, especially in those under 34, often delayed testing, believing their symptoms weren't serious, a lack of access to mental health and other supportive care. And so it's created a number of issues as well in our system that is common cancer focused. There's a lot of out-of-pocket costs for diagnostic tests. People often had to drain savings to access testing. Patients in rural and regional areas facing extra barriers to access subspecialty care, and they were 3 times more likely to decline a recommended treatment due to the distance compared to those living in metropolitan areas, and often a lot of lack of readily available information. So this came off the back of a Australian government Senate inquiry into this issue, and over the next few months, there's going to be a series of national workshops with various cancer control experts to try and look at ways to better care for people with rare cancers. There's a number of recommendations in this report outlining ways in which we might be able to improve equity, speed up diagnosis, and ensure comprehensive support for all cancer patients, including the rare cancer patients. So I'm sure that's an issue in New Zealand as well, Kate and Chris. Our paradigms are sort of based around common tumours, not necessarily about rare diseases.
I think also our paradigms are based around big centres with everything there. And I don't know what it's like in Australia, but people don't want to move to another island to have their therapy. They need to be with their loved people, with their own own environment. And there's that pull, isn't it, between expert and local? Pull all the time.
Yep. As how do we better manage that? How do we better link and network the experts to ensure that treatment can be delivered as close as home as possible where it's safe to do so? So it's a thought-provoking report. And so again, we have a broad listenership, and I'd urge people to have a look at that. We'll provide a link. And then I wanted to talk about a couple of other guidelines as well. So just a sort of segues into just talking about the access to care, Kate. There was a report from ASCO published in Supportive Care for Cancer and Standards and Practice Recommendations for Telehealth in Oncology. MASC endorsed practice recommendations developed by the American Society of Clinical Oncology. The Multinational Association of Supportive Care in Cancer, or MASC, through its Digital Health Study Group, used a framework called the Agree-to instrument, which is a formal process to assess the quality of guidelines, and found them to be methodological sound, clearly presented, and highly applicable to practice. They basically endorsed them rather than writing their own. And they do feel that they could be now updated because they're a few years old, and they were then planning to do that jointly together. So MASC and ASCO are under the process of updating those guidelines. But I think that's still of relevance for clinical trials, but it's also relevant for day-to-day care. And as we talked about, Kate, how can we better network centres to ensure patients are in the centre and we can minimise travel where we can. There's a really good table in that paper too with some practical suggestions. And so again, I'd urge people to have a look at that. And the last thing I wanted to mention is a statement that's come out, a joint statement from ASCO, COSA and ECHO, Principles for Advancing Healthy Workplace Cultures. Sabe Subison, who has led a lot of the work in Australia and internationally on telehealth in oncology. Sabe has just become president of COSA, and one of his goals is to try and highlight this issue about healthy workplace cultures. The paper points out that the WHO projects a global health workforce shortfall of 11 million professionals by 2030, and a contributing factor is rising levels of workforce burnout, which leads to clinicians working fewer hours, in some cases leaving clinical practice altogether. We have an unbalanced distribution of workforce between metro and rural areas and between high income and low income, middle income countries. So to put in place some principles for advancing healthy workplace cultures so we can attract and retain more healthcare professionals in what, let's face it, a very exciting and rewarding specialty to work in, but a very tough specialty as well.
Well, I think that's fantastic leadership, really, by Sabe. The people who you work with and the way in which you work with everyone every day is what keeps you going throughout oncology. Obviously, we get into it for the patients, but, your colleagues are what keeps you in it. And in a good department is just absolutely and utterly, there's no better substitute for a good department. When you're having a bad day, having colleagues there lifting you up when you're feeling low, and simply being able to be there for others at a time in which, they need it as well, is something which is, I think, one of the most beautiful, wonderful things about being in oncology, really. In New Zealand, we have relatively smaller departments in other places, and so we also have quite a nice national network of friends and colleagues too, which I think is important for fortifying each other too. So getting that culture right, getting those relationships and helping each other and supporting us through what as you say, is a challenging but beautiful specialty.
Fantastic. All right. Well done, everybody. What kind of wide-ranging number of topics as usual. Hopefully people will find that interest. Please feed us back some feedback, else papers that you've come across that you think we should cover and highlight to others. Keep those coming in as well. And thank you, Rachel.
Always a pleasure. Thank you.
Thank you, Chris.
Kia ora. I'm going to see if I can say goodbye in Te Reo Māori. So, he kono rā.
Thank you and goodbye.
Mā te wā. Goodbye. See you soon.
And as I'm in Bordeaux, I'm going to say au revoir or à la prochaine fois. See you next time. And bonne journée. À tous.
Craig, can't you say, I'll have a bottle of your best red in your best French accents? Isn't that what you're about to say at lunch?
Je voudrais une bouteille de vin rouge, s'il vous plaît.
Oh, passé, Kate. Okay. Till next time. See you all soon. Bye.
That's it for this episode of the Oncology Journal Club podcast, where oncology papers meet real-world practice. If you'd like to explore the papers we discussed today, head to oncologynetwork.com.au and visit the Oncology Journal Club tab, where you'll find show notes, links to the research, and a growing collection of OJC resources. Don't forget to join the Oncology Network. It's free. You can send us voice notes and chat with us on social media. And physicians, you can also claim CME points for listening to this show. This podcast was proudly produced by the Oncology Network. Until next time, thanks for listening.